Okay, well, everyone, hello and welcome, and thank you for joining this breast cancer awareness event, which the Women's Forum of RP is hosting in honor of the Breast Cancer Awareness Month. I wanted to thank our president, Dr. Jonala Gadda, for letting us having this event. Breast cancer, as you know, is a very important disease in which affects about 1.3 million women a year. That is the number of cases which are diagnosed. About 458,000 deaths occur due to breast cancer every year. We do see this more in the low and middle income countries because the diagnosis is made pretty late. Today we have four amazing speakers who will shed more light into this topic and talk about it. Without further ado, I would like to introduce our president, Dr. Sudhakar Janalagadda, who has given us this opportunity to host this event. Dr. Janalagadda.
Good morning. Thank you, Anjana. Thank you very much. And I look at some statistics, very frightening. In US, you're expecting about 276,000 cases expecting diagnosis this year, 2020. And about the 2,600 men will be diagnosed with breast cancer. Other surprising, every 2 minutes, woman will be diagnosed with breast cancer. The very thing we need to know. The awareness is very important. I really thank the Dr. Anjana Samadar and team put up this first time in the webinar way. And thank you, Anjana and Udaya and Dr. Aramali and Dr. Kusum and Bhavani are doing this event. Thank you. We welcome all the great speakers today. Thank you.
Thank you, Dr. Janalagadda. Now I would like to introduce our moderator and our co-chair, Dr. Shyamala Aramali, and she's going to moderate the whole event. Dr. Aramali.
Thank you, Dr. Samadar, Dr. Janalagadda, Dr. Udaya, for giving me this chance to moderate this one. This is so close to my heart. And before that, I would like to introduce people who don't know me. I'm Shyamala Aramali, practicing internist in Atlanta, Georgia. This would be a great day. Isn't it awesome, like RP Women's Forum doing this breast cancer awareness in the month of October, breast cancer, what Anjana was telling. Don't miss the pink, pink color, okay? Yeah. And I see somebody else wearing, yes, Uma, yeah. This is all about, before going into this, and Dr. Sudhakar has given a brief, this thing of cancer incidents. And so 1 in 8, that is kind of 12%. So other speakers are there in line to enlighten about this. But I would say, being women and physicians, a lot of patients, they share their fears and sadness about the breast cancer. And more so recent times, we see one of our friends or close relatives being the victims of breast cancer. To be frank, as a woman, I would be lying if I don't say I get a bit anxious when I'm awaiting for my breast mammogram results. Saying that, I would proceed to introduce our first person to introduce Dr. Datta, Dr. Bhavani Srinivasan. She is so many hats to switch. I don't know how she manages, right? And she's the co-chair of Women's Forum, RP, and she's the vice president of BOT, RP. She's ex-president of RPQLI, and so many more. Before it's getting late, I would introduce Bhavani. Bhavani, take over to introduce Dr. Datta.
Thank you, Shyamala, for that very nice introduction. And straight from the beach, I'm going to introduce our next speaker. But before that, I would like to say that breast cancer is extremely personal, in my opinion, and for me, because I lost my mother to breast cancer. So it's a very poignant topic for me. And every year I try to conduct a seminar on breast cancer from RPQLI. every October. And this afternoon, that will be happening as well. So, on with the program. It gives me great pleasure to introduce our speaker, Dr. Datta. He is very well known, well liked, and well respected in the Long Island community, much sought after by patients. The moment, they have any surgery, oncology wise, breast cancer, otherwise, whom do they think of first? It's Dr. Datta, and they try to go to him and to get the best treatment possible. So Dr. Rajiv Datta is the Chair, Department of Surgery, Director of the Division of Surgical Oncology and Head and Neck Surgery, and Medical Director of the Mount Sinai, South Nassau, Gertrude and Louis Feld Cancer Center, and Professor of Surgery, Icahn School of Medicine at Mount Sinai. Dr. Datta is one of the leading head and neck surgeons in the US and an international leader in surgical oncology. A fellow of the American College of Surgeons, Dr. Datta earned a medical degree from Grant Medical College in Bombay, India, my med school, and completed a surgical oncology fellowship at the renowned Tata Memorial Hospital, the largest cancer center in Asia. He completed an internship and residency in general surgery at Maimonides Medical Center in Brooklyn, New York. The following year, he served as a research fellow at Memorial Sloan Kettering Cancer Center and chief resident at Maimonides Medical Center. This was followed by a dual fellowship in head and neck oncology and surgical oncology at the prestigious Roswell Park Cancer Institute in Buffalo, New York. He spent 2 years in the United Kingdom, where he became a fellow of the Royal College of Surgeons. Dr. Datta's approach to comprehensive cancer care is one that combines the most advanced surgical techniques with a warm and caring attitude that enables both patients and their families to feel comfortable and confident while making important medical decisions. Today, Dr. Datta is going to talk to us about effect of COVID-19 on breast cancer management. Dr. Datta? Dr. Datta?
Yes.
Maybe he has to unmute.
Okay.
Oh.
Thank you, Dr. Bohani, for that very kind introduction. Also, good morning to all, and thank you to the organizers for giving me the opportunity to speak today. I thought the most important thing which we are all facing is COVID-19, and it has affected the breast cancer management. So I'll just be brief on my presentation. I have no disclosures. So we all know that, once the virus started in end of December last year, it started to come to the United States in the end of January. We all started to see cases around February, but it was March 11th when the WHO declared COVID-19 officially as a pandemic. And that's when the treatment of the patients got affected. At the same time, the United States also declared national emergencies. And one of the directives to all of us was to stop all non-essential surgeries. And this obviously was being done because we wanted to protect all patients from COVID. We wanted to save our resources. A lot of staff time was required. And more importantly, nobody was sure, how does this disease spread? What are the effects? And we were all learning as we were going around. I'm sure each one of us has seen many articles coming out on a daily basis, either through JAMA or New England Journal of Medicine. And we were all trying to read on a daily basis, trying to understand this disease. All the government agencies, the most important ones for us being the CDC and CMS, with the local and state government, we actually were told as a directive that no more elective surgery. In fact, we had to submit a list on a daily basis. What kind of cases are we doing? Which means when it came to cancer surgery, it did delay a lot of treatment protocols. All the screenings were delayed. And to combat this, all the societies now, since we're talking about breast cancer, in breast cancer, there was a consortium We call that COVID-19 Pandemic Consortium. And these included a lot of professional societies, which included the American Society of Breast Surgeons, the American College of Surgeons, the American Society of Clinical Oncology, plastic surgeons, radiology, and they all came together to come up with a criteria of what to do in this pandemic, because all the resources in every hospital were being directed towards taking care of COVID patients, and what's going to happen to the breast cancer, we were not very sure. So this became a difficult time for everybody. Now, patients, right? I mean, getting a diagnosis of breast cancer by itself is very scary. On top of this, COVID-19, uh, on top of this, having COVID-19, which was also causing a lot of problems with the patient. There was starting to be a stigma with COVID-19. Already cancer has a big stigma. On top of it, anybody who got COVID, people just wanted to run away from them. And of course, a difficult time for physicians because, when we treat patients, we have a straightforward pathway. We all follow NCCN, which is National Comprehensive Cancer Network. So we were all trained to do the patients see imaging issues, you get a biopsy, and then you do the staging, then you do the planning, you have a multidisciplinary conference. Well, all of it was out the window completely. We were not allowed to follow normal pathway, and that caused a lot of anxiety to all the physicians. And based on the COVID-19, we had to start making treatment modifications. Now, let's talk about the surgery, because being a surgeon, what I had to do, we have about 18 operating rooms. I had to shut down 16 of them because our ventilators were being modulated to become ICU ventilators. All my staff was loaned out to medical ICU. My surgeons, my residents, my PAs, we had given everything towards COVID. So we're down to 2 operating rooms, which were being preserved for emergencies. And so there was no way we could have done an elective breast lumpectomy. Now, even if it did, the number of beds required for post-op were down to almost nil. So we are a hospital of about 425 beds. We had about 505 patients, and 90% were COVID. So there was just no place to keep patients. Our ICU, which is a 22-bed ICU, which means we have 22 ventilated patients, we were up to 95 ventilated COVID patients. So there was just no way to take care of breast cancer patients. So we had to, even if somebody had to operate it, even if the patient normally would stay, let's say, one night, they had to be sent home the same day. Similar issues happened with chemotherapy and radiation. Our chemotherapy infusion unit, we actually rigged it so that it was moved towards the front of the hospital. We took one of the conference rooms and cafeteria and converted that into infusion center so that the patients can enter it directly rather than going through the hospital. And we did the same for radiation. The breast imaging obviously was not available because everything was shut down. And more importantly, access to clinical trials and fertility preserving procedures was just not available. There was just no way to enroll somebody because number one, we didn't have staff. All our research nurses, research staff was again loaned out to COVID patients. So there was literally no one to do any of the paperwork required for these procedures. Now, when we talk of patients with breast cancer, first of all, when they undergo treatment such as chemotherapy, it does affect the immune system, whether it's targeted or chemotherapy. So anyhow, these patients are walking around with weak immune systems. And then some of the treatments with the targeted therapy can cause lung inflammation. So these two made the patients high risk for COVID. And of course, if the patient had any of the comorbid conditions such as age greater than 65 or COPD, kidney disease, diabetes, heart conditions, obesity. This confounded the whole thing. So patients with breast cancer on chemotherapy, not only the physicians were scared for them, even the patients were scared for them. So we had to come up with protocols. How do you self-isolate? I mean, all these things were unknown. How do you self-isolate somebody at home without actually making sure that they can live life at the same time, not be at risk? So we had to come up with protocols, ideas, plans, and to have some kind of making sure that the entire organization is following the same pathway. We started to have an administrative phone call on a daily basis where we went through the PPE for the day, what are we doing in the operating room, what's happening to the ICU beds, and how are we following the protocols of isolation. So everybody was trying to learn on a daily basis. And as we had to bring in patients for either surgery or for chemotherapy or radiation, we started to establish things which are now pretty standard, but those days were very new. We started these phone interviews prior to the visit, having to take temperatures. And it was interesting that how do you even take temperature? Because nobody wanted to use thermometers because that would cause more infection issues. So that's when everybody started to look for these infrared thermometers for patients. The universal masking protocol. Now, obviously, as surgeons, we are used to having a mask and a eye shield and a hat and a face shield, but rest of the people were not used to this. So it was a lot of education. The N95, they were running out of stock, which everybody knows. I think every hospital went through that. Then came physical distancing. And the physical distancing, now we obviously know it's about at least 6 feet or more. At that time, nobody was sure. What is distancing? I mean, people were using the term social distancing, stay away from each other. And one thing was sure that to come up with 6 feet was going through various protocols and ideas. And nationally, finally, the CDC came up with this guideline. And to avoid this, we made sure that there was more time between the appointments, patients were waiting in the car. And then we had to come up with a plan of doing COVID tests before surgery and chemotherapy. And that also, how long is the test valid? No one was sure. So this went back and forth with the New York State. And finally, we were given directive that it has to be between 3 days, 3 to 4 days prior to the procedure. Anything beyond that would not be valid because patient may get reinfected. And then came the visitors. I mean, this was the hardest time. If you operated upon a patient, you could not have post-op visitors, which patients were used to. So initially there were no visitors. So all the post-op and everything was done on the phone with the patients. If the patient had to be operated, we just could not do any reconstructive procedures. So patients who have free flaps, one of the most commonest procedures is called a deep flap, that was just could not be done. So these patients had mastectomies and either had no reconstruction or just had an implant. So these patients did require additional surgeries later on as the COVID started to wane. They were brought back again to do additional procedures. A lot of patients, we changed our protocol. We started to use neoadjuvant, which basically means doing chemotherapy up front or hormonal therapy up front. So patients who are ER/PR positive were getting hormonal therapy prior to surgical procedures. So we kept modulating, trying to change things so that somehow we can continue some sort of treatment for these patients. The infusion centers followed the same plans that we tried to limit the number of patients in the infusion centers. There was social distancing, COVID testing prior to every procedures. And then the issue came, what happens if the patient is COVID positive? How long do you delay? A week, 2 weeks? Do you retest? If the retest is positive, what do you do? I mean, these things we were all trying to learn on the go. We were trying to learn with the patients. It's interesting that the patients were also reading. So the articles which were coming out in national news and press, they were read by the patients and the doctors at the same time. That was an amazing part. We've never had that ever before, where patients saying, no, it says 2 weeks. I don't have to retest. And the doctor saying, no, I think I have to retest. He said, no, here's the article. And it was amazing to see everybody engaged in this thing. And obviously all breast screenings were put on hold at that point. Now coming forward at this point, obviously there has been a drop in COVID-19 numbers, thankfully, which happened. So we did restart all the operative procedures. There was quite a bit of backlog, and we started to, first of all, take care of the patients who were seen in February, March, April, and these patients who had either started chemotherapy, then we had to interrupt and do surgery, or had surgery, which was only mastectomy with no reconstruction. We did their reconstruction. We brought back patients for screening. I can tell you patients were very scared to come back for screening or any of the treating facilities. We all had to do videos for the patients to show that somebody's cleaning everything, changing the linen, cleaning the floor so that the patients can come back. The problem is that we are starting to see, not second, maybe we are at the third surge maybe. And that is starting to scare everybody, that where are we going to go with this? And of course, time will tell whether the vaccine will come on time or whether the surge will go down. People will learn from social distancing. We have no idea. There still seems to be a stigma attached with COVID. You should see if somebody says, I was with somebody who had COVID, people just run the other way. We currently have, like all the other hospitals, instituted a a test which we take it off the cell phone to make sure that attestation that we have no fever, no cough, nothing, that we have not traveled anywhere. If that happens, we can enter the hospital. In the hospital, the visitors have started, but they are very limited. So a lot of changes which we've all gone through. One thing is for sure that we did learn quite a bit. And in the pandemic, back to the breast cancer, obviously there was low incidence recorded. And it's not because the incidence was low, which everybody knows. It's because there was no screening, no biopsies, nothing was done. So that's why the numbers were low. And of course, we're low in surgical procedures. Like February, March, April, we do about, at our hospital, 900 to 1,000 procedures a month. We were down to like 20. And most of them were dire emergencies. And of course, there was delay in starting these treatments. And so a couple of things come out of COVID, that we don't know how COVID actually affects the patients on the cancer at a cellular level. We're still not sure. And the reverse, how does the patient who has cancer will affect the COVID-19 outcomes? So I'm not talking about lower immunotherapy. I'm just talking about if somebody has cancer, how will COVID affect the patient? Our main goal was twofold, right? Protecting the patients from COVID and treating their cancer. And that took a long time to get this thing. So in my closing note, all I will say is that as the third surge is coming, I can say that, and I think most of us will agree on this, that we are definitely better prepared this time. We have enough stockpile of PPE, ventilators. I mean, we bought so many ventilators from all over the place, from Florida, from Mexico. I don't know, we just stockpile all the ventilators. We're better prepared in education for all the healthcare people. Additionally, patients are also well prepared. They understand when you tell someone you cannot come to the hospital, they understand. Everybody understands. So I think we might be better prepared. I'm not sure that we'll do a complete shutdown like what we had to do in February, but I hope that this does not happen. So thank you for your time, and I would be happy to take any questions at the end of the session. Thank you.
Thank you very much, Dr. Datta. This is very informative talk. We would be asking you a few questions after we finish all the rest of the speakers. So we were, if we get some time, we will ask the audience also some questions if they would. And without any delay, I'm going to move on to the next speaker. Dr. Udaya is going to introduce. I think all RP people know about Udaya. She's well known. She's currently holding two positions. So she's the publication committee chair, RP, and advisor to the Women's Forum. And she's the president of RP chapter, Mississippi. And you see her all the time. In the fashion shows and all, she has her hand there for the RP. And Udaya?
Thank you, Bhavani. That was, sorry, Shamla Aramali, that is a very kind introduction about me. Thank you so much. And thank you all for being here today. As last 6 years, I can say, though I am a patron member for more than 2 decades, I worked as a chair and co-chair, and now last 2 years I've been advisor for this Women's Forum. And normally we do during GHS in India and also annual convention or the Women's Forum. I've been seeing this Women's Forum growing, from just newborn to now adulthood, I can say now, because every event we had, usually the event was attended more by men than women. It's so funny. But now we have to shift the gear a little bit. And because all this happening, our phenomenal president, Dr. Sudhakar Jonnalagada, and he's very energetic and he's always boosting us to come up and do something different. And thank you, Dr. Jonnalagada. And also we have an amazing chair, Dr. Anjana Samadar. She is a great leader and she's energetic, always comes out with the new ideas. So she shifted the gear altogether and she wanted to make a Facebook. We have about 450 women physicians and family members are there right now. And also we have planned, I think, series of webinars and with different education and many other, we are going to enlighten, that is the future plan. And also she's not only wanted to bring in leaders, women leaders from, or any leaders from United States, she also wanted to bring leaders from all over America. So, and also we have such good, amazing co-chairs and members are supporting this cause. Without further ado, I know Dr. Datta spoke how our current situation, because of the COVID, how the patients are affected, how he has to postpone the surgery, and how it's going to affect the breast cancer patients when they get a COVID also. With a combined form, we are really suffering. So now, without further ado, I would like to introduce very young, enthusiastic Dr. Nawal Sheikh. She's a neuro-oncologist working as an assistant professor at University of Mississippi Medical Center in Jackson, Mississippi. She is the site principal investigator for a progressive brain metastasis from any solid tumor trial at UMC Brain Tumor Program. She's a member of our local RP chapter, and also she has become recently the national member, and also she's a co-chair of our health awareness committee in our RP Mississippi, and she's instrumental in bringing our next speaker. Please welcome Dr. Nawal Sheikh to introduce our next speaker. Hi, Dr. Nawal, the stage is yours.
Thanks, Dr. Udaya. Thank you much, and thanks for the kind introduction. I'd like to thank RP's, National RP's president, all the leaders and the organizers of today's event. This is a great event. And I'd like to give a shout out and congratulations to Dr. Samadhar's miraculous and triumphant recovery. It is very inspiring, and I just hope that we all learn from this, and Almighty God bless you and bless all of us in this unprecedented times. It takes me and gives me immense pleasure to invite the next speaker, Dr. Shu Ching Tang. He has a very impressive and, as expected, an illustrious lengthy CV. So I'm going to talk about important achievements in his lifetime. He's a tenured professor of medicine and pharmacology and toxicology at UMC, and he's the associate director of Cancer Center and Research Institute. He's also the director of experimental therapeutics, and in that position, he leads the phase 1 program at UMC. Dr. Tang obtained his MD with honor from West China University of Medical Sciences in China and PhD in molecular biology. He then went on to do his residency training in Edmonton, Alberta, and he, after that, did his fellowship at the world-reputed Princess Margaret Hospital in Toronto, Canada. He currently serves in multiple committees, and not limited, but includes SWOG Breast and Immunotherapy Committee, the NCI SWOG IMAT Steering Committee, and the San Antonio Breast Cancer Symposium Abstract Review Committee. He has held several leadership positions, such as division head and the breast cancer program director at various academic institutions, both in Canada and America, including University of Miami, Mayo Clinic, University of Colorado, and University of Augusta. Dr. Tang was the founding president of ACOG, Atlantic Canada Oncology Group, and the founding member and scientific advisor for the BCIRG, as well as the National Scientific Advisor for US Oncology. He has served as a principal investigator and has authored multiple and several landmark studies in breast cancer, especially on new drugs. He was very active in the basic research around the molecule BAG1, which I'm pretty sure a lot of the breast cancer surgeons and oncologists involved here are aware of. BAG1 is one of the 16 test genes in the FDA-approved oncotype RT-PCR multi-gene prognostic and predictive gene test for early breast cancer. Last but not the least, he serves as the associate editor for the International Journal of Cancer and Clinical Research. He's the editorial member for the Journal of Cancer Studies and Therapy, the Journal of Modern Oncology, and the Chinese Journal of Lung Cancer. And he has published extensively in the fields of research in all his different positions. So I welcome wholeheartedly and very excitedly Dr. Shu-Ching Tang.
Thank you, Dr. Sheikh. Thank you for your nice introduction. I would like to thank API and the president and the organizer for such a wonderful meeting for Breast Cancer Awareness Month. And also want to thank Dr. Shivani for your kind invitation. I'm going to discuss today a topic of immunotherapy to change from the prior topic of pandemic on a more upbeating note. We know that immunotherapy, how do I advance the slide? Okay, here.
We can't see the slides, Doctor.
Can you?
No, we can't see the slides.
Ah, okay, hold
Share
on.
screen, please.
Can you see it now?
Does it
No.
give you the option of share screen?
Yeah, I thought we did it earlier. Hold on.
Dr. Jayanti, where can you find the option of share screen?
We tried earlier and
Okay, can we
Sure.
maybe go on to Dr. Jayanti, and by the time he can try to fix that?
okay, hold on. I got the screen back.
In the bottom, you can see the green button.
On the left corner at the bottom, there is a green.
Yeah.
I think. it's fine.
Okay.
Can you see it now?
Yes,
Yes.
yes.
Okay,
Go ahead.
thank you. I'll put it.
So like in there here. Like, so what do you want me to tell?
Okay, now?
I thank them or they're here?
Yes, it's on now. You can go ahead.
Okay, good.
You can go ahead, Dr.
Yeah.
Tang.
Sure. Yeah, I'm going to talk about immunotherapy in breast cancer on a more upbeat note. And we know that checks and balance of immunotherapy is vital in eliminating pathogens, including cancer cells, while protecting the host cell tissues. I was thinking this is probably the best audience to discuss about yin and yang of immunotherapy immune system in our body. We know that immunotherapy was hot in the 1980s when I was doing my PhD in Canada. At that time, Steve Rosenberg discovered a variety of ways to stimulate the immune functions. Although, as you know, immunotherapy went from hot to cold for the next 30 years until recently when a group of factors called checkpoint inhibitors were discovered. In fact, in 2018, the Nobel Prize in Physiology or Medicine was awarded to Dr. Hangju and Dr. James Allison. And Dr. Hangju was awarded due to his discovery of PD-L1 on T cells, while Dr. Allison discovered another important molecule called the CTL4. We know that suppression of T cell activation by PD-L1 and the CTL4 was considered one of the most major escape mechanisms for cancer. And for breast cancer, we started to realize there's a variety of molecules that either stimulate or inhibit the immune function in our body, which enable the cancer cells discovery and the detection and ultimately escape as well. And in addition, besides immunotherapy that can stimulate the immune function, we are now learning the side effect from immunotherapy because anything is a double-edged sword. And we're seeing some unique autoimmune toxicities from immunotherapy, including those toxicity that was observed from several breast cancer trials that was presented recently, including thyroid abnormalities, skin reactions, adrenal insufficiencies, hypophysitis, pneumonitis, hepatitis, and colitis. These are all side effects from the immunotherapy when you wake up the immune system too much. In fact, we studied one of the immunotherapy molecule called indoximab a couple of years back. We actually encountered a patient who developed the full-frank Parkinson's disease as a result of this drug. And we did a brain scan and SPECT scan, which showed proof that indeed this is drug-related. So we are now seeing a wide variety of autoimmune toxicities as a result of immunotherapy. So we do need to balance the efficacy with these toxicities. In fact, we did a meta-analysis several years back of all immunotherapy ever published under the sun. Indeed, we showed that all immunotherapy produce autoimmune toxicity, especially CTL4 inhibitors, followed by PD-1 inhibitors, and followed by PD-L1 inhibitors. And we know that immunotherapy for breast cancer is actually currently lagging behind that of melanoma, renal cell, and the lung cancers, because that's where immunotherapy was first pioneered in clinical practice. And breast cancer was behind because it's considered a cold tumor compared to hot tumors such as lung cancer and renal cancer. That is because breast cancer has a small or no percentage of what we call the tumor mutation burden. Because in order to trigger immune response, you need to have a neoantigen sitting on the cell surface. And these neoantigens are produced by cancer cell gene mutations. So that's called tumor mutation burden. And the breast cancer is low compared to other type of tumors. So the question is, how do you turn a cold tumor to a hot tumor to trigger immune response, such as breast cancer? Of course, there are several strategies you can do that. You can either give tumor chemotherapy or radiation therapy, which can damage DNA and produce new antigen as a result of tumor mutation. And this has been now applied in breast cancer. So the first immunotherapy that's approved for immunotherapy in breast cancer is atezolizumab based on Impassion 130 trial, which when added to chemotherapy such as Abraxane, is significantly increased the overall survival in the whole population, especially in those patients whose tumor overexpress PD-L1, that is a biomarker for immunotherapy. So now, as we know, even with the wonderful immunotherapy available, they are not a cure. Most patients still progress and the tumor become resistant. The question is, can we move beyond the current checkpoint inhibitors? And many times when talk about immunotherapy, people equate the immune recognition and stimulation as a gas pedal versus the tumor suppression and tolerance as a brake in the car race. But in fact, we are starting to realize in order to win the car race, you need to have a nice weather, you need to have a good road condition. This is now called tumor microenvironment and immune innate system that is important in immunotherapy, in addition to having a gas and a brake pedal. So in fact, we are publishing a review article about immunotherapy in development. I call the current existing PD-L1 inhibitors as the first generation. And the second generation, of course, are checkpoint modulators. These include some inhibitory and even more importantly, stimulatory molecules that are in development. And more importantly, we need to look beyond that, look at the third generation. These are the molecules can modulate tumor microenvironment, such as macrophages, stromal cells, such as fibroblasts, or blood and lymphatic vessels, such as endothelial cells. And finally, they are looking at the innate immune system, such as IDO inhibitors and even gut microbiome. So those all play an important role in host immune system and the tumor tolerance and escape. And in fact, NCI and SWOG has now formed the new IMATCH study steering committee, and I'm fortunate to be invited to be part of it. We're going to launch a nationwide immunotherapy study and to identify biomarkers for response to immunotherapy. We're going to match the patient to appropriate biomarkers. And this study has now buy-in from all cooperative groups across the country. And we're going to also do the translational study to validate immunotherapy response biomarkers such as tumor mutation burden or tumor inflammatory profiles. And this study is going to be launched next year across the nation. This is a mirror image of the MATCH study that is now finished. So it has a similar concept and idea and support from the NCI. And SWOG actually was considering a similar trial. We call it umbrella trial. Umbrella trial is a study that look at many molecules in one organ, such as breast cancer, to look at the immunotherapy in metastatic breast cancer, more importantly in ER-positive tumor. And I was honored to be co-chairing of the translational research arm of this study. And this was a very ambitious study that's going to enroll hundreds of women and then randomize them to receive durvalumab, which is the immunotherapy plus a partner drug in many arms, which can boost the immune response. Unfortunately, due to funding reasons, this study is currently put on hold. Now, in our center, we are actually doing some novel trials, in this case, a phase 1 clinical trial to look at Immunina and its role in combination with the pembrolizumab, which is immunotherapy, and also chemotherapy such as docetaxel in advanced solid tumors. And Immunina is a patented spirulina extract developed at the National Center for Natural Product Research at the School of Pharmacy here at the University of Mississippi. Its brand name is called Immunina. It is currently licensed by Chromadex and marketed as a dietary supplement. Now, as we know that spirulina is actually a gram-negative photosynthetic filamentous cyanobacterium. It is one of the most popular nutritional supplements. Like many nutritional supplements, it's supposed to do wonderful things such as immune modulation, cholesterol reduction, anti-cancer, and antiviral activities. But what we do know from our preclinical studies, Immunina actually do enhance immune system by acting through toll-like receptor 2 to boost the immune response. So in our phase 1 study, we're going to combine this drug again with immunotherapy such as pembro and docetaxel in any patient who have failed standard therapy. Now, an important issue is about the biomarker. We don't have a biomarker for immunotherapy because talking about precision medicine in this biomarker, whether should it be PD-L1, this is still not known. Could be tumor mutation burden or a tumor infiltrating lymphocyte. Should it be T cell, B cells? Should it be immune cell subtypes? Or should it be cytokines such as IL-2 interferon? Or should be tumor inflammatory profiling? And also people are studying immune response signal pathways. And finally, there's a gene signature panel that's being studied, such as pan-cancer IL-360 involving 360 genes, but none of this has now been validated yet. So we know, this just summarizes my presentation. We know that immunotherapy is indeed revolutionizing cancer therapy across tumor sites, including, of course, breast cancer. And many additional targets and pathways are being explored to increase the anti-immune response and to overcome the resistance. And I should add also to reduce the autoimmune toxicities. In fact, right now, atezolizumab is the only immunotherapy approved for breast cancer, although many new ones are coming. What we need is a novel strategy to develop to target all breast cancer subtypes, including ER-positive tumor, HER2-negative tumor, and HER2-positive breast cancers. On that note, I'll finish my presentation and be happy to entertain some questions down the road. Again, thank you for your attention.
Thank you very much, Dr. Tang. This was so informative, and hopefully in the near future, we are going to get a good innovative immunotherapy for the breast cancer, especially for the resistant relapses. So you are the ones, academicians, who do the work and get the drugs to the front that can be treated properly. Thank you so much. The questions would be later. Before I go on introducing the third speaker, I would like to recognize or acknowledge our dear EC who are here today, starting with Dr. Anupama Gottimukala, the President-elect API, and Dr. Ravi Kohli, the Vice President API, Dr. Amit Chakravarti, the Secretary API, and Dr. Satish Katula, the Treasurer API, and Dr. Suresh Reddy, the ex-API President. Thank you for being here. So next, I will move on to our third speaker, very dear to my heart, very close, hometown mate, Dr. Jayanti Srinivasaya. And she's going to speak about breast cancer, what is new. And she's popularly known in Atlanta very dearly by her patients and the physicians, Dr. J. And she graduated from Bangalore Medical College. Then she went to Illinois, Iowa for residency internal medicine. Then she came to her hometown, Emory, for fellowship in cancer and hematology and oncology. To tell about her professional memberships or her awards, I have to take her time out, steal the time, 10 minutes to give her medals, awards, her participation. She has been an awesome hematology oncology. That would be, we mutually have some patients who come back to me and rave about her so much. And she has, to tell few of them, she works in DeKalb Medical, Emory University, Johns Creek, Gwinnett Medical Center, almost all the hospitals in Georgia and Atlanta. And to go back to the membership. She's the Medical Association of Georgia, DeKalb County, and the American Society of Clinical Oncology, Georgia Society of Clinical Oncology. And she leads a lot of committees, Cancer Committee Chair, and Committee of DeKalb Medical Center leadership, and few of them, I'm telling. And coming to the honors and awards, there are like few pages of them. She's awarded as the best physician, top 10 physicians, and compassionate physicians awards. And before I go too much, and I would introduce Dr. J. Please welcome Dr. J.
Thank you. Can you all hear me?
Yes.
Yes.
So thank you, Shamla, for the kind introduction, and thank you, RP Committee, for having me here this morning. I'm so excited that you're focusing on Women's Forum and what we're doing in breast cancer. Now, the two speakers before me kind of gave the scenario of one, what we're doing in COVID situations, and how science is still advancing, simultaneously. So I thought I would use two of my patients as examples of both situations. So we'll advance the slides. First, I'll give you some general information about breast cancer, and especially in Indian women, how this might behave. And then we'll talk about two patients who have gone through their course of illness with all the new therapies that are available. And we're part of clinical trials, like Dr. Tang just mentioned earlier about the trials of immunotherapy and how they've survived their disease beyond expectation. So just going back to some of the basic facts about breast cancer. Shamla already had said 1 in 8 women have breast cancer. What that in the United States? What that means is if 8 women were born today, 1 of them will end up developing breast cancer. But of course, we are 1, that's a very high incidence. 2, we are also focusing on women who are higher than that risk, which could be genetic or other risk factors as well. In the United States, at this point, there's an estimated 276,000 cases that will occur, and 48,000 new cases of breast cancer, of in situ breast cancer. But 64% of these will be diagnosed at early stages, and we can show with our clinical trials and therapies available that 99% of these will end up surviving for 5 years. So if you're picked up early, you do well. So, so that's the statistics in the United States. Next slide. Next slide, Shamla. Can you move? Okay. So this is not only the statistics in the US, but if you look at worldwide, breast cancer is the most common cancer among women worldwide. Next slide. So in India, if you look at the statistics, even there, breast cancer is the most common cancer in women, more in the cities than in the rural areas. About 32% of female cancers are breast cancer in India as well. Somebody, I think, first said, every 2 minutes a woman is diagnosed with breast cancer in the US. Probably every 4 minutes in India, which was much lower in the years past, but it's catching up to the US statistics. 1 woman dies of breast cancer every 13 minutes in India as well. So what are we doing that might be causing these cancers? Next slide. So we also know that in India, when breast cancer is diagnosed, they are diagnosed a little bit later. So you see later stages in many of the patients. And in addition, there's a higher incidence in the 35 to 50-year age group. And so why is that happening? Though they have children early in life, they may be breastfeeding, which are protective things, but still have a higher incidence. So there may be something about the genetics of that cancer. Next slide. So there is, just like we have the SEER data in the United States that we look for statistics among our population, there is this International Agency of Research that publicizes its data, the National Cancer Registry Program in India as well, which is called Globacon. Next slide. So about 25% of cancers in women are breast cancer. And again, the deaths are also 25% of all cancers are breast cancer deaths in India as well. Next slide. Again, this circular diagram shows that 25 to 49-year age group have a very high incidence of breast cancer in India, which we need to study more. But just so that, because we have many Indians who have migrated here are in that age group, and there are also people who have adapted to lifestyles here, and how does that change? There have been preliminary small studies showing that not only we may have inherited risk, but also we may be increasing that risk with our diets and other factors in this country. Next slide. Keep going. So this next two slides is for you to read at your convenience, looking at the other age groups in the Indian population, 50 to 69 and 70 and above. Again, all of these confirm that about 25% of all women's cancers are due to breast cancer. Next slide. This diagram, bar graph, shows that if you pick up breast cancer early, you have a higher chance of cure. And now not only are we looking at the pathology in terms of when we pick up the cancer, but the biology matters as well. So now in women who are diagnosed with breast cancer, we look at genomic testing. That is, we study their tumors in the labs, which gives us a recurrence score, which tells us how aggressive to be with their adjuvant treatment after surgery, and which helps them achieve that high percentage of cures. So, so the recurrence score is becoming a standard in patients who have estrogen positive breast cancer. And we know that if they have a low recurrence score, they have a higher chance of 5-year survival, greater than 95%. Next slide. So we as a cancer community, we follow what we call as NCCN guidelines. This is just a representative slide. It just tells us that this is how we follow when we treat our patients. We have algorithms for every disease, and we try to follow them to the best of our ability. And again, individual populations may deviate from this, but this is kind of a basic framework that we follow. And this can be accessed by any non-cancer clinician as well. Next slide. Again, this slide I just use as a representation to say that if a woman has estrogen positive breast cancer, 5 years follow-up is not sufficient. We are seeing recurrences even up to 20 years. So these patients who may have low-grade cancers, who are estrogen positive, who you think may have been cured, can have recurrences very late, and they need to be followed, because many of the internists who are listening to this talk may be following these patients. They may not be coming to the oncologists or other cancer specialists, and the primary care physicians need to know that these patients have to be followed very carefully for their symptoms. There is no standard imaging guidelines, but you go by your symptomatology. Next slide. And you may also see that many of these patients will be on anti-hormonal therapy beyond 10 years, sometimes even up to 15 years for individual situations. So that is something they need to be aware of as well. Just kind of briefly touching up on breast cancer risk factors. We all know that hormonal risk and age are two major risk factors for breast cancer. So women, but men can also get breast cancer, which may be more genetically inherited. Aging, of course, increases risk of breast cancer. Next slide. So keep genetic risk, which means if you have a genetic abnormality in all the cells of your body, which may be BRCA gene, which is the first gene that was identified in the breast ovarian cancer syndrome gene. But there are also other genes, which I'll show you with my case, that can predispose to breast cancer almost tenfold. So if we are talking about 1 in 8 women getting breast cancer, if you carry a genetic abnormality, you may be as high as 7 in 8 women. So that's something that you need to be aware of. Next slide. So family history, irrespective of the genetic abnormality, may be a risk factor because of how you live, how you eat, your exercise routine, and your diets. Personal history of breast cancer could increase contralateral breast cancer or recurrence in the same breast as well. So those are all the risk factors. Next slide. So we talked about genetics. Move on to the next slide, please. Next one. So chest radiation for other diseases like Hodgkin's disease may increase risk of breast cancer. Next slide. And postmenopausal hormone replacement therapy, which was shown by the Nurses' Health trial, confirmed that the duration of hormonal therapy after menopause could increase risk of breast cancer, and DES and hormone contraceptives as well. Next slide. Race, like we talked about, the Indians having maybe earlier incidence of breast cancer, African Americans having a more aggressive type of breast cancer, or maybe diagnosed a little later. The last point that I want to make is this dense breast tissue. Now, many of us women, when we go for mammogram, now we are getting a report saying women have dense breast tissue, or this particular study shows dense breast tissue. What does that mean? Even if you have a 20% increased density in your breast, they use that sentence, heterogeneously dense breasts. So in that situation, we know that that is a high risk factor, and you would recommend a 3D mammography, or what we call as tomography. So please order that on your patients if that's, that result comes out from your mammogram. Next slide. So then you keep going, breastfeeding does decrease risk of breast cancer, and the age at which you have your first child increases risk of breast cancer if it's beyond 30. And if you have menarche early in age, so anything that increases hormonal risk will increase your risk of breast cancer. Next slide. So physical activity and overweight, a lack of physical activity increases risk, and alcohol intake in higher amounts can increase risk as well. Next slide. So now I will, of course, we'll be having questions maybe related to this, which I can answer later. And I'm going to go to 2 cases very quickly just to show how my patient, MG, she was diagnosed with left breast cancer in 1997. She's still alive in spite of having her cancer come back in many parts of her body. And why is she still alive? And what have we found with her? So initially in 1997, she was treated with, she was ER positive breast cancer, HER2 negative, which we think is a fairly, easy cancer to cure. But this lady was initially treated with chemotherapy and tamoxifen. Next slide. Next slide. So next slide. Keep going. So basically, I will just tell you about what happened. I think we don't have the correct slide here. But this lady, after 3 or 4 years, had a recurrence in the same breast. Then we found that she ended up being BRCA2 positive, because in 1997, we didn't have genetic testing yet at the time. But she had had multiple family members with breast cancer, and she was BRCA2 positive. So at that time, we decided that she would have both her breasts removed, get chemotherapy again because she had a recurrence in the same breast, and continued on with hormonal therapy. Next slide. So next slide. So basically, this lady ended up having a recurrence of her cancer in 2015 with in the bones and the lymph nodes, but she's still alive to date. The reason she's alive is because of new treatments that have been available. Next slide. There are 3 new drugs that have come out for breast cancer, which are called PARP inhibitors. They work through the PARP pathway, which is a DNA repair pathway. And like Dr. Tang mentioned, we now have matched trials that are available. Originally, she was on the match trial, which matched her to the PARP inhibitor. So we know that in the DNA, the two strands, when the strand breaks, you can have PARP that comes in and repairs the DNA. But these PARP inhibitors will prevent the repair of the DNA in the cancer cell, and patients who have BRCA2 abnormality already in one of the alleles will then not grow the cells back. And this is called the PARP inhibition. And she has been in all three of these drugs, and she's still alive and well in 2020. So we're talking about 23 years of having had cancer. And this is an exciting time for us in terms of knowing these targets. Next slide. So these are many of the trials of PARP inhibition. I'm going to keep having you go forward to my case 2, Shamla. Yeah. So keep going forward. This olaparib is one of the drugs. Keep going forward. So this is another PARP trial that is available for prevention of breast cancer, which is ongoing at this time. Next slide. So what are the future developments? We talked about the various pathways. We now have, for cancers, breast cancer cells, we have IOs, which is immunotherapy, the PD-1, PD-L1 inhibitors, CTLA-4 inhibitors. We have PI3K inhibitors, which is in the orange, AKT inhibitors, oral SERDs, which is again downregulating the estrogen pathway. Then we have new novel chemotherapies that are coming in, and the HDAC inhibitors. So we have a long way to go in terms of our patients that can receive multiple lines of immunotherapy and targeted therapy and improve their outcomes. And this is an exciting time for us. Next slide. So this is case 2, which is CR. She's another lady who was diagnosed in 2013. But this lady had a more aggressive breast cancer, which is called triple negative breast cancer. So we don't have any targets for hormones. So what do we do with this patient? She received chemotherapy, but then her cancer promptly came back because these are very aggressive cancers. Next slide. So she then was re-biopsied. So one thing we know now is that when a cancer comes back, and if it comes back several years later, we biopsy the cancers again because there is a 20% chance their type can change. And this lady, when she was first diagnosed, was HER2 negative, and then she became HER2 positive and received Herceptin-based therapy. And next slide. Then she had another recurrence 3 years later, which is a liver biopsy was done, and then it went back to triple negative. So the biology of these cancers change over time, and that is why we re-biopsy. And then we also look at what we call as Foundation 1 testing or Tempest testing, which is looking at the genomics of the tumor. Next slide. So this lady ended up having PD-L1, and which Dr. Tang mentioned, she received the atezolizumab, which is called Tecentriq, that's the trade name. And then there is a new trial that she is now currently on, which is called sacituzumab, which is another monoclonal antibody. So for a triple negative breast cancer that recurs within 2 years of having had the cancer, the chances of dying is, the median survival is 1.5 years. And she's now at year number 8, and she is alive and doing well because of all our recent therapies and targeted therapies. Next slide. So I just want to reiterate to you that clinical trials of breast cancer are exciting now with all these new immunotherapy combinations. And please remember to send patients for these trials, encourage them to participate in trials, especially as ethnic minorities. We need to participate more so we can get more personalized therapy for our patients and improve our survival. And I'm going to stop there because, we'll have questions later. Thank you.
Thank you so much for this incredible information. It has been I'm not surprised. I know you, right? Okay. Thank you. Thank you. And let's move on to the next speaker. And guess who is going to introduce Dr. Shweta? Our First Lady, Dr. Uma Jannalgadda, practicing physician from Douglas, Georgia. She accepted to introduce our next speaker, Dr. Sangvi. Dr. Sangvi, she's from Los Angeles, West Coast. So we brought her as the fourth speaker so that she can have little more sleeping time because she's 3 hours behind. So Uma,
Thank
go
you,
ahead and
Shyamala.
introduce her.
Thank you, Shyamala, for your kind introduction. I'm Uma Maheshwari Jannalagada. There's nothing more important as a First Lady for being a part of raising awareness for breast cancer. And I'm so excited to introduce my next speaker, Dr. Sweta Kukriti Singhvi. She's an MD PhD. She's a physician scientist specializing in breast radiology and biophysics. Sweta graduated summa cum laude with a bachelor's degree in biochemistry and honors biology from the University of Illinois at Urbana-Champaign. She was a Howard Hughes Research Fellow. Following, Sweta joined the UIUC Medical Scholars MD PhD program. She pursued molecular imaging and device development study at UC Irvine Bergman Laser Institute. Sweta also worked in biomedical optics at Laboratory for Fluorescent Dynamics. Sweta's interest in breast imaging began at that time using lasers to non-invasively visualize molecular metabolism in vivo. Analysis led to the discovery of quantitative biomarkers for breast cancer detection, resulting in a new cancer diagnostics. Sweta pursued residency in diagnostic radiology and subspecialty fellowship in breast imaging at the David Geffen School of Medicine, UCLA. She served as a teaching assistant in Department of Internal Medicine and Physics at UIUC and Biomedical Engineering at UC Irvine. Sweta is a diplomat of American Board of Radiology. Currently, she serves as an attending physician in a large private practice group in LA. She has broad leadership experience from writing curriculum of university leadership courses. Currently, she is on the board of directors of the Physicians Scientists Association. Sweta is passionate about mentoring students in science, medicine, and technology. She's trained in Bharatanatyam and Kathak dance, enjoys long distance running, and delights in French language. Without further ado, please join me in welcoming Dr. Sweta Kukriti Singhvi.
Hi, good morning.
Hi.
Thank you very much for your kind introduction. I'll go ahead and share my screen here. And thank you very much for inviting me to this forum. Quite an honor. Let me just get this screen share going. I take you don't see my slides, correct?
No. No.
So someone has to allow me to share. It says one participant can share at a time.
Share screen, should I?
Vidya?
Yeah, there is no one else sharing, so you can share it, doctor. Anyway, I'm changed it to multiple participants. You should be able to share now.
Some had put in the chat that the previous presenter needs to stop sharing the screen for the next presenter to share their screen. I don't know if that can help.
I did that just now. I said share.
No,
that
we
happen?
already stopped it actually.
Yeah, I think someone has to allow me to. Okay, so that's someone else's screen.
Yeah. Now I closed her.
Dr. Tan here. I see on the share screen, you can either one participant or multiple participants.
Yeah, we saw that.
Yeah, I just got it. So we'll get it going here. Okay. Okay, great. Again, thank you very much for the kind introduction and thank you very much for inviting me today. So let's go ahead and get started. So I'll be talking about breast imaging, screening, and diagnostics. So as we've gone over statistics already, but this is just to remind you that 1 in 8 women has a chance of developing breast cancer in their lifetime, which is about 13% of the population in the United States. That means globally is 2 million. So 2 million is the number of cancer-related deaths each year. Some more statistics, which we've seen already. About 280,000 new cases of invasive cancer will be seen this year in 2020, as predicted by the American Cancer Society, and about 48,000 cases of carcinoma in situ. And the number 42,000, that's the approximate women who will die from breast cancer this year alone. Breast cancer risks, as we've seen already, so just to remind you, breast cancer risk increases with age, the older you get, so it's more likely diagnosed after the age of 50. Genetic mutations, as we've talked already about, for example, BRCA1, BRCA2, the reproductive history, menses before age 12, or menopause later in life after age 55. Dense breasts, and we've talked about it, but we'll get into the details a little bit later. Detection is just more difficult on mammography because of the dense breasts. The personal history of breast cancer, and then having something such as ADH, which is atypical ductal hyperplasia, or LCIS, which is lobular carcinoma in situ. And then of course, having a family history of breast cancer, for example, first degree relative, which would be the mother, the sister or daughter. And having a previous treatment with radiation, for example, for lymphoma before the age of 30. But not all is doom and gloom. And so I want you to see here, a lot of the cases as described as localized by the SEER data, which is the Survey Epidemiology and End Risk Results data maintained by the NCI. And what that means, localized is confined to the primary site, meaning the breast. So if 63% of the cases are localized, they actually have a 98% chance of 5-year survival, which is great, which is actually fantastic. Regional means spread to the regional lymph nodes, which is about 30% of the cases, and that's 85% or almost 86%, which is also amazing. And then distant, which is 6%, has approximate rate of survival about 28%. So mammogram and screening. So here in this talk, I want to focus on the radiological aspects of it and how we pursue breast cancer. So here is the number I want you to remember, which is the age 40. According to the Society for Breast Imaging and the American Cancer College of Radiology, this is when we begin screening for breast cancer if someone is of average risk. So here is what we typically obtain. Here's a typical mammogram. We obtain 4 views, the right MLO, which is medial lateral oblique, and the left MLO, as well as the right CC and left CC, which is craniocaudal. So 4 images is what we typically obtain on screening. Here is an example of a malignancy. So the density that you see on the mammogram, where the line is going through, that's a cancer. And the image on the bottom left, that's that cancer on ultrasound. This is just to point out that masses and calcifications, malignant calcifications, can be detected within 1 year of screening, meaning someone had a clear or normal mammogram in 1 year. The following year, they may have a mass that large. However, as I just emphasized, I want you to remember the age of 40. I want you to also know that there are other societies with other recommendations. So you will see in some institutions, they follow the US Preventative Task Force, which is every 2 years starting at the age 50. And there are different institutions which follow American Cancer Society where they say from the age of 40 to 44, patients have the option to start screening every year. From age of 45 to 54 every year, and after age 55, it would be every 2 years. Risk calculation. So there are multiple models, but the ones that we use is called the Tyrer-Cuzick score. And the reason we use this is because this is the model which includes breast density. And you can see there's a whole litany of features that they use: age, age at menopause, pathology results from the prior biopsies. But the most important point to drive out of this is that if the number comes out 20%, that's where someone becomes high risk. So what is high risk screening? Someone, again, who has BRCA1 or 2 mutation. And I'd like you to understand what this algorithm is, because when you refer patients, they need to come to us at the right time. So if someone has the mutation or they're untested but have a first-degree relative, mother, sister, daughter, they need to start at the age of 30 with screening, but not before 25. Or if someone has a mother or daughter who is diagnosed premenopausal, they need to start at age 30, not before 25, or 10 years before the age of diagnosis of the younger relative, whichever is later. That's the time they should be coming to us. Other high-risk screening, as I mentioned, 20%, same thing. History of radiation for lymphoma, you would start 8 years after radiation therapy, but not before age 25. And then if someone has been diagnosed with LCIS, which is lobular carcinoma in situ, ALH, atypical lobular hyperplasia, atypical ductal hyperplasia, DCIS, which is ductal carcinoma in situ, or invasive ductal carcinoma, they need to be coming into us yearly after that diagnosis. So this begs the question of when do you stop screening? You know, there is really no particular guideline, but this is what we follow from the SBI, Society for Breast Imaging, and the ACR. And it's when the life expectancy is about 5 to 7 years on the basis of other age or other comorbid conditions, or when abnormal results of screening would not be acted on because of these issues. Now, so I just spoke about screening mammogram. We also have screening ultrasound. However, I want you to understand that screening ultrasound does not replace screening mammography. It is complementary, which means you do not skip the mammogram. So who do we order this for? This would be for someone who is high risk, for whom MRI may not be possible for some reason, or for example, with dense breast tissue. We also have screening MRI. And again, screening MRI is not the replacement for screening mammography. Screening MRI, again, is complementary, and that would be for someone with a 20% lifetime risk. So you have an idea of what breast cancer looks like on MRI. These are the common sequences which we obtained. I won't go over the details, but as you can see on the left breast, there is a mass. And these different sequences, the T1 non-fat saturated, the STIR, the axial post-contrast, these allow us to characterize these lesions. And here you can see on the post-contrast subtraction, which means all the background has been subtracted. This tumor, which lights up in blue, yellow, red, is very heterogeneous. And you can see that here on the sagittal view, and here on the bottom right side, you have a 3D lift. So this is to show you what it looks like. So here we have screening MRI, so who would you do that for? You would do it for BRCA1 and BRCA2 carriers starting at age 30. Again, you would do that for a untested first-degree relative of a proven BRCA carrier. You would do it for someone who has a history of chest radiation. And you may consider this for someone with a risk between 15 and 20%, depending on the individual factors. So these are the patients for whom the screening MRI should be ordered. So what are we looking at? So in radiology, these are the imaging findings. We're looking for a mass. On the left, we have a round-shaped mass. In the center, we have an oval-shaped mass. And on the right, we have a spiculated mass. And that is bad. The more it becomes spiculated and irregular in shape, that is more suspicious of malignancy. We're looking at calcifications. So on the left, we have coarse calcifications. Then we have amorphous calcifications, which look like a bunch of dots. Then in the third screen, we have fine pleomorphic. They look like shards of glass. And then on the right side, they're linear or fine linear branching. And they're incredibly small. These images have been zoomed up significantly to show these to you, but these are the suspicious characteristics that we are looking for in that huge image, as I showed earlier. But not all calcifications are benign. And so here we have calcifications which are, sorry, not all calcifications are malignant. Here we have calcifications which are benign. And so these are examples of what we would call benign calcifications, lucid centered, they look like an eggshell in the second one, or they just look very round and punctured. Now, here we have other findings. This is what we call the developing asymmetry. And this brings me to my point of the prior mammograms are very important. It is very important that when a woman comes into the breast center, she brings her priors, or that the clinic or the doctor's office sends the priors to us, because it is the comparison which is needed and very vital when we're looking at this. So as we go from the left to the right, you can see with the arrows, which have kindly denoted to us what is developing. And that is the malignancy which is developing. And it's looking at it in time, which helps us to identify these things. Here we have a finding which we call the asymmetry. And as you look at the tissue on the right side, the MLOs, which is the medial lateral oblique, there isn't anything there. But on the left side, or on the right side of the screen, which is the craniocaudal, on the left breast, you can see where the arrow is pointed. There's something a little different. And that's what an asymmetry means. It just means there's tissue which looks a little bit different. Other findings we are looking for distortion. Distortions happen when the tissue starts pulling in. And the arrow has kindly showed us where the distortion here is. We are also looking for what we call the focal asymmetry. Focal asymmetry means two images, two planes. We see it by the arrow shown on the MLO view and on the CC view, and here it's magged up. So it's a finding seen on two views, which we raise questions. So diagnostic imaging. So here's the algorithm for which you need to be ordering the studies for your patient when they come to us. So if a patient presents to you with a breast lump or breast pain, and they are under 30, it would only be an ultrasound. If a patient presents to you over the age of 30, then you need to order for them a diagnostic mammogram and ultrasound. If a patient comes to us and we see for a breast lump, but there is nothing there on mammogram or ultrasound, sometimes a diagnostic MRI may be ordered. So if you see that referral come in or recommendation come in, don't be surprised. Other findings, axillary lymph node enlargement, you would order a diagnostic mammogram and ultrasound. Nipple discharge. If a woman presents to you with red or clear, unilateral, spontaneous discharge, they need to be ordered a mammogram and ultrasound, and ultimately we will recommend an MRI for them. And finally, post-lumpectomy, if you have a patient coming into you after lumpectomy, order a diagnostic mammogram and possible ultrasound, which allows us to evaluate the next case. So this is kind of the algorithm for you. If you're a practitioner who's referring to us, or even then, if you're not referring to us, you should know these are the kinds of studies that we look for. So what does the standard report come for? This is an example of one of my reports. I've simplified it here for the purposes of this talk. So we have the exam description, 2D, 3D digital mammography, the history, screening mammogram, breast density. So I'm going to go over these parts: breast density, breast tissue. I write these sentences: there are no suspicious calcifications, masses, or tissue distortion. Impression: no mammographic evidence of malignancy. Recommendation: annual mammography, 5-ADS1. In our reports, we tell you what the findings are, we describe the breast density, we give you our impression, and we literally tell you what to order next, which is the annual mammography. And then there's this word BI-RADS. So I'm going to go over and explain all these concepts. So breast density, several years ago, it became mandate slowly across the states. As of 2019, 38 of the 50 states, including DC, require description and notification of breast density. And why is this important? The reason that we say it's related to increased risk is because it is just harder to detect malignancies with density, because they both look very similar. They're white, literally. So on the top left screen, we have a breast which is almost entirely fatty, which is what you would call black or gray on this screen. On the bottom right, on the bottom left is what we call heterogeneous. Part of it is white, part of it is black. The center screen is also what we call heterogeneous. And those are the ones where we put in that disclaimer saying this may obscure small masses. And it's for that reason, as I just explained. On the top right side, we say scattered areas of fibroglandular tissue. Fibroglandular tissue is the white. And then on the bottom is extremely dense. And those are incredibly difficult to literally see through. So understanding BI-RADS. BI-RADS is the breast imaging and reporting system. This was initially developed in 1993 by the ACR, and now we are in version 5. So you're going to see these on these reports, so you should understand what they mean. So let's go ahead and elucidate this. So BI-RADS 0 just means there's some questionable finding and we need further evaluation. There are some calcifications, a mass, a tissue distortion. A, we need the priors, or B, we need to do that diagnostic algorithm that I just went over in terms of getting a diagnostic mammogram or ultrasound. BI-RADS 1 means negative. There's really nothing to talk about. BI-RADS 2 means it's benign. There are benign calcifications, as I showed to you. There can be a benign mass, for example, what we would call a fibroadenoma, some biopsy clips, some post-surgery changes. Then there's BI-RADS 3, which is probably benign, and I'll elucidate this more. What is that? That would be a fibroadenoma. It is very common for women who are premenopausal to have fibroadenomas in their breasts, and that's totally common. Or some focal asymmetry or some round calcifications. And again, this is through time and evidence that we have found that these are things that are probably benign. BI-RADS 4 means suspicious. That is malignant appearing. And BI-RADS 5 means if anything else comes back to us, which is not malignant, patient still needs to go to surgery. 6 just means it's known. So the question is, what's the management and what's the chance of cancer? So the main things to point out here is when they're BI-RADS 2, they're benign, it means it's almost 0. Of course, nothing in life is 0, but it's almost. BI-RADS 3 just means it's very probably benign, so just a short-term follow-up, 1 month, 6 months, it depends on the case, but the chances are 0 to 2%. BI-RADS 4 means we need to do biopsy. Now here the range is quite wide, from 2 to 95%, but it's split into these 3 categories. And when we are looking at cases in our minds, we think about where it would fall in. BI-RADS 5, as I mentioned, means biopsy. It means there's more than 95% chance this is malignant. And 6 means, it's, as I said, biopsy proven. So what's the next step? And so if you have a patient who, or if you know someone who has a fibroadenoma, we typically follow them for 6 months, all the way for almost 2 years, until we see 2-year stability. Invasive ductal carcinoma, that is surgical and oncological consultation and an MR. Ductal carcinoma, on top of the surgical and oncological consultation, we often order breast MRI for the extent of disease. And I will show you a case where we see this. Sclerosing adenosis, we return to screening. Atypical ductal hyperplasia, that is surgical excision. A papilloma, surgical excision, and lobular carcinoma in situ, surgical excision. So this is for you to understand so that when your patients come back to you and they have these findings, you're going to see our recommendations because we do something called RAD-PATH. RAD-PATH means that after a patient has undergone radiological imaging, they've had the biopsy, the final report, the pathology and the imaging, we review it, the person who did the biopsy, and we determine, is this concordant or not? And then we make a final recommendation on what the next step should be. So the patient is treated in full cycle. We see them from the beginning to the end, and we want to make sure that all the T's are crossed and I's are dotted before they come back to you. So now we talked just a little bit about digital tomosynthesis, but let me just explain what this is. So we had a digital full field mammography, and this was the new thing that happened after those after the screening mammograms got digitized, basically. But now we have something called DBT, so that's digital breast tomosynthesis. What this means is that there is a method by which the X-ray tube literally rotates in an arc about 15 to 40 degrees to obtain a set of low-dose digital projections through the compressed breast. The women in this group know that when they go for their mammograms, the breast is significantly compressed. But through that, there is an arc and the tube is going over your head. The 2D images are then synthesized or reconstructed into a stack of high resolution images, usually about 0.5 to 1 millimeter in thickness. And that's how we're able to get 3D imaging. It's almost like, if you can imagine, 2D is literally just a snapshot. 3D is almost like getting, it's like the CT of the breast, just as an analogy, but that's kind of what it is. So it allows us to literally go through multiple stacks of images so we can see more. And as you can see from this image, it allows us to delineate what would be two lesions, which would be on top of each other, and you wouldn't be able to tell that there's two, versus here you can see there's two different. How this helps, it decreases our false positive rates because we are able to have better visualization of the lesion, and also we have better evaluation of the superimposed tissue. Remember, in a 2D image, the cancer, which looks white, is similar to the fibroglandular tissue, which also looks white, which is why it becomes difficult. But in 3D, we are able to literally move through all these images to tell what it is. Here's an image of a Hologic unit. This does not mean I support Hologic versus GE or some other company. It's just to show you an example of what a mammogram unit looks like. And so the X-ray tube, the X-rays will be coming from the top there. Here is an example of the images from the DBT. And so indeed, it would be incredibly useful for dense breast tissue because we're literally moving through the different 2D images. It has been found to increase detection rates, for example, DCIS, which is ductal carcinoma in situ and invasive. And then we call back less because we're able to figure out and see what's going on. So there's a projection image. The second image is a tomo slice, which means 1. There's something called synthesized, which means that the computer basically creates a 2D image off of that 3D information. And then the conventional one. You can see it's pretty good. They're looking really good in terms of for us to identify and look for cancer. So here are some cases. So here we have a patient that's a 42-year-old lady with diagnosis of left breast DCIS who presents for MRI. And why they do MRI is to look for extent of disease. Now, even on the slide that I've created, it is incredibly hard to see these calcifications. And so you can imagine on a monitor, it's still pretty hard. But there are these tiny little foci, which are the calcifications. And they look really small in a small area. But when you do the MRI, you see that there is a large area on the left breast, which is what we call clumped non-mass enhancement. And in fact, it is greater than the area of the calcifications. And this is to show you that while the calcifications can occupy a small area, that DCIS in reality involves a much larger area. And it was the MRI which allowed us to see that. Here is another case, a 40-year-old lady who is status post-excisional biopsy for the right breast, which had ADH, and now we have a new finding of a right breast mass on MRI. So I've circled it here on the right side. The mass is irregular. It has spiculated margins, which are all suggestions that it's suspicious. It has rapid washout kinetics, again, more suspicious. This ended up being DCIS. And so this is just an interesting case because a patient may have ADH and look, we did MRI, and we thought that there is.
人讲的长，最后一个现在讲完了，我们要讨论。
The patient also has DCIS. So it's an example to show you how MRI helped in these cases. So I just want to end by reminding you again that this is Breast Cancer Month. Please remember to go get the screening mammogram. Remind your friends to go get their screening mammogram. And I want to thank you. And here we have a view of Chicago. Thank you for inviting me, and I'll be happy to answer questions.
Thank you so much, Dr. Shweta Singhvi. This is so clarifying. I know we have always questions from even the physicians. What is the age we have to stop? When do you start? And it's very nice algorithm, very clear. In the same context, I would like to ask a question because of the time constraints. I'm going to ask one question each speaker. So whenever I meet my patients, I have two questions they ask me. One is, it's very painful. Second one is the radiation. Is there anything coming in the near future without causing pain to get this device done? And about the radiation also, they're like, as you said, the 3D is a low dose, but sometimes they do 2D, then 3D also, that would be the double dose, right? So what is your clarification? How do we answer or convince my patients about the pain and the radiation?
Sure. So first question, which is the pain. The reason that there is pain is because we need the breast to be compressed. And we need that because if we are able to decrease the surface area by which the X-ray tube is putting out the radiation, then the patient can have less radiation. And that's our goal. We want to have less radiation. Now, mammography, there really isn't anything much I or any of the radiologists can do about that compression. In terms of the future, I can share with you some of my research that I've done during my time as in PhD, which has now gone on to Toshiba. And we actually were inventing lasers, which is using light and optics so that you could non-invasively detect breast cancer and you could non-invasively differentiate benign and malignant masses, meaning cancer versus fibroadenoma. And we actually, this machine has actually gone through trial, through the Akron trial. It is now with Toshiba. It is going through further patenting, and it's becoming as small as a cell phone at the current time. And this is led by Bruce Stromberg, who is now the director of the biomedical optics at the NIH. So we are working on technology because we understand it's not exactly fun to get a mammogram. To answer the second question of radiation dose, I completely understand. So here, I want to give you an idea of what that is. So for that, basically, a mammogram right now with 2D, it's about, let's say 1.6 to 1.9 milligram. And those two images, just for your information, that is only about, so in 1 year, a person just by living and breathing on Earth, they're gonna get 3 millisieverts of radiation. And that total combined is 0.7. So it's a third of that. And if you look at the other modalities, it is literally nothing compared to the other modalities. You talk about PET, that is much more. That's 25 millisieverts. 0.7 and 25 is majorly different. But yet, this is what allows us to help save lives. Literally, there's a 30% decrease in mortality. When we talk about tomosynthesis, indeed, it is almost a double radiation. But then again, if you look at the total numbers like I just described for you, it's still incredibly small because 0.7 plus 0.7 is still 1.4. And in milligrays, that would be about 1.5 to 1 double. But still, all of that is under the required amounts by the FDA. And it allows us to see and gain all this information from it. So I want people to understand, people are scared of radiation, but just by living and breathing, it's all around them. And this is literally nothing compared to a PET scan.
Thank you. Thank you. That's very clarifying and encouraging to know there is something pain-free. Laser is coming. Yeah. So we could get more patients to get convinced. This is really vehemently, they refuse to go, oh, if they hurt you, I'm not going to go. I got bruised. Thank you. Thank you so much, Sweta. And I would go to the next speaker. I have a question for Dr. Datta, if he's there.
Hi.
Hi, hey. You know what, you spoke about cancer, women and all. Is there any difference in surgical management about male cancer? Because they have hardly any breast tissue, the involvement of the deeper pectoralis muscle or anything different you approach male or female breast cancer?
So for male breast cancer, stage for stage, their outcomes are similar. However, because of paucity of breast tissue, they'll end up getting mastectomy most of the time. So it's very hard to do breast conserving surgery for male patients. As for the female, there is a lot of push for breast conservation therapy. We are part of the National Accredited Breast Cancer Centers, and they actually monitor our breast conservation rate. So there's a lot of neoadjuvant treatment being given. Additionally, there is oncoplasty, which is a specialized type of breast surgeries become standard of care. So we try and avoid mastectomy as much as possible. So oncoplasty helps in doing major lumpectomies at the same time preserving the shape and the size of the breast cancer. And then there are a lot of additional plastic surgical procedures being done. And lastly, when it comes to reconstruction, everybody heavily relies on free flaps. One of them is called the deep flap, which is based on the inferior epigastric artery from the abdomen. But right now the push is on the breast conservation.
Thank you. So this is very common. Like my patients, when they come, they have little bigger mass. Am I going to lose my breast? Are they going to do mastectomy? That is their major concern. Thank you for letting us know. We can use this in our practice with our patients, definitely reassuring. Thanks. And the next question would be to Dr. Tang. So you were doing research on BAG1 with breast cancer. Are there any associated cancers you found out with this, apart from breast cancer? This is for Dr. Tang.
Thank you. BAG1 is a anti-apoptosis molecules. Apoptosis is programmed cell death, and the function is it functions as a molecular chaperone that tag a lot of protein for degradation. So it controls a lot of proteins half-life, such as ERPR, which we discovered, and is expressed besides breast cancer in other tumors such as lung cancer, cervical cancer, head and neck cancer. In fact, not only we were the first to discover its prognostic value in breast cancer, but also we published the first paper of its prognostic value in lung cancer. So it play a wide variety of physiological function and also in cancer. And we also discovered this role in modulating resistance to tamoxifen treatment. And also in resistance to chemotherapy. So it has a role to play in other tumor as well. So its potential remain to be discovered.
Thank you. Thank you so much. I have a lot of questions for Dr. J. Before I project other questions, I have one personal thing. You spoke about HRT, longer HRT and prone for more cancers. How about we are seeing more and more younger age population? If they want to conceive, become pregnant, have children, what is your advice?
I mean, in terms of birth control pill use? Or?
No, that is HRT will cause, but once you treat a younger person who wants to conceive.
A person who has had breast cancer, can they conceive? Is that the question? A person who has had breast cancer, can they become pregnant?
Yes.
The current recommendation based on clinical trials is that if they have estrogen positive breast cancer, women can get pregnant 5 years after they've had breast cancer. And if they have estrogen negative breast cancer, it's thought that in 2 years they could conceive and become pregnant. Now, in terms of preserving fertility, we do have trials looking at hormonal suppression with LHRH agonists. We use Lupron during chemotherapy to preserve fertility. And of course, now with all the other infertility therapies that are available, getting pregnant after chemotherapy is much easier if they have a uterus in place. So that's the current recommendations, that they can get pregnant if they have estrogen positive disease after 5 years. But we also, on the other hand, if a woman is pregnant and has breast cancer, there have been studies again proving safety and efficacy of chemotherapy during pregnancy, especially in the 3rd trimester, maybe late 2nd trimester as well.
How about there are some people, breast cancer survivors, menopausal. They come up with severe menopausal symptoms. Do you recommend low dose hormone therapy, or you strictly say no? What do you?
Strictly say no because of the risk. Again, there have been very occasional patients that we have had no choice, but We have other modalities to negate the side effects of menopause, which for hot flashes and other symptoms like that, we have many drugs which are non-hormonal. We use clonidine, which is a blood pressure medication. We use venlafaxine, which is an antidepressant. Those tend to help with the hot flashes. Vaginal dryness, we have some methods now where very occasionally I do use local estrogen creams, but most often we use laser therapy now to stimulate the glands in the vaginal area for dryness. So that has become, it's not approved by the FDA yet, but many clinics have started doing that in a 3-part setting, which I send patients for that. In terms of other risks of osteoporosis, we have many drugs available. Heart disease risk, we have other drugs available. So we try to avoid hormonal therapy, especially if they've had estrogen positive breast cancer.
What is your recommendation about these laser therapies for atrophic vaginitis, they say?
That is the one that it's in a 3-part setting where it's locally you stimulate the glands to secrete for secretions. And that is monthly for 2 months, and then it's at a 6-month. It's not covered by insurance now, but it's the costs are reduced by some of the gynecologists, oncologists, or gynecologists. So we refer them for that. Yes, and there's no contraindication. That's,
thank you. Thank you. So I have another question from one of your colleague oncologists. I will read out for you. This is Dr. Satish Katla from Ohio. Dr. J, could you please explain audience briefly about the utility of breast cancer index in deciding on extended adjuvant hormonal therapy?
Okay. I think I saw that question come through. So extended, the first recommendation was for 5 years of hormonal therapy, tamoxifen for premenopausal women, and aromatase inhibitor for postmenopausal women. But subsequently, the SOFT and NEXT trials have come out, which we can still use aromatase inhibitors for premenopausal women with ovarian suppression. And 5 years has been proven. Beyond the 5-year mark, there's one study called the ATLAS trial for tamoxifen, 10 years versus 5 years. And that again has shown additional benefit. ATAC trial extension, which is B42, is showing between 5 to 10 years, and JMA 17 showed that 10 years is better than 5 years for AI therapy. So I currently use 10 years for most of my patients. Beyond the 10-year mark, does the BCI index help us? There are no randomized prospective clinical trials, but I use my judgment based on the patient's toxicity to hormonal therapy, the cost, the coverage by their insurance, and the patient's interest to continue, and other toxicities. Again, you cannot use BCI index yet. It's not a category 1 indication yet, but at the same time, you can use it for an individual patient based on all these factors.
Thank you. Thank you so much. There are so many other questions, but I will let them personally email you or anything because of the time constraints. And thank you all so much for this incredible presentation seminar. I would like to bring back Dr. Anjana Samadar, who's a fighter. You know, she had 93 months of ICU stay and all the complications of COVID. And she came back to lead us for the Women's Forum. Incredible. Anjana, you come over and take the podium and introduce Sajni now.
Sure, absolutely. Thank you, everyone. Thank you, all the wonderful and amazing speakers. We learned a lot today. Each one of you took your precious time off. And thank you, everyone, including the officers who attended the event and made it successful. At this point, I would like to introduce Dr. Sajni Shah, our BOT chair, to give a vote of thanks. Thank you, Dr. Sajni, Dr. Shah. Dr. Shah, are you there?
Almost.
I think.
Sorry, I'm here. Yeah, I was muted, so I just needed you guys to unmute me.
Sorry. Okay.
Thank you so much, everybody. This is a really wonderful series of conferences and speakers. I think breast cancer is so important. Yeah, I'm sure most of you, like myself, have friends and colleagues that have been affected by breast cancer. Some are survivors and are doing well, and some unfortunately have succumbed to disease. It affects women and men, young and old, and this was a really great opportunity to learn the new, and breast cancer and the treatment modalities change so often, and it was really a fantastic platform to learn about the current and new treatments and diagnoses for breast cancer. So thank you, everybody, for such a wonderful talk and discussion.
Okay, back to Anjana.
Yeah, thank you everyone again for coming, and we will have amazing talks probably every month, to give awareness, especially women-related diseases, and also we'll have other diseases also where we will have amazing speakers. My team is working very hard on it. Thank you, Dr. Ramali. Thank you, Dr. Shivangi, Dr. Junlagatta, Dr. Bhavani Srinivasan for helping organize such a great event. I would like to once again thank all the speakers for taking their time off and giving us such important information. Our next event, actually, we are having a musical program on November 7th, and we will send out flyers and information very soon. Hope all of you can attend that. And it is a pre-Diwali musical event, and my whole team is working very hard to make it very, very successful. Thank you, Dr. Junlagatta, our president, for giving us all this wonderful opportunity. Thank you.
Thank you.
Bye. See you all.
Okay.